At its very core, drug science must remain independent. This means we don't accept sponsorships. It's with the support of the drug science community we're able to do this and make the podcast in the first place. If you're able to become a drug science community member and support the show, you too will be supporting the dissemination of evidence-based drug policies. Without you, none of this would be possible. For anybody interested, there's a link in the show notes. Thank you. Hello and welcome to the Drug Science Podcast with me, David Nutt. Here we're bringing together experts and activists for a rational, honest and informed conversation about drugs. Welcome everyone to this Drug Science Podcast. And today we have two people on the podcast at the same time. And that's because they're almost always spoken about in the same breath. The Mithoefers, pioneers of many things, but particularly known to all of us as the pioneers of MDMA therapy. So welcome, Annie and Michael.
Thank you, David. It's really, really good to see you and a pleasure to be here. Yeah, we've been together for 50 years now, so we've kind of melded into one unit in a lot of ways.
Thank you, David.
Yeah, well, at the end, we'll start talking about the secret of a happy marriage, but probably most of our people are listening to this wanting to understand where you came from and how you got the idea of doing MDMA therapy and how you've managed to basically be the absolute pioneers in this field. So who's going to kick off and tell us when this crazy idea of using MDMA for therapy came to you?
I guess I had the crazy idea first, but she was close behind. Really, even though we've been doing clinical research now for a little over 20 years, we're really clinicians, basically, who were forced into research by the clinical need, basically, in my case. When I was in training, I didn't think I was interested in research very much. So it wasn't till later, after 10 years of practicing psychiatry, first 10 years of practicing emergency medicine, and then 10 years of practicing psychiatry after that, that I was just, became increasingly aware and dissatisfied with some of the treatments, the treatments we had available for many people. So it was really, I'd been in college in the 60s and I experienced psychedelics then and kind of left that thinking they were important, but leaving it behind for many years, several decades. And then Annie and I did have the opportunity to experience MDMA with a therapist several times back when it was legal. So we had a sense of what these compounds could do. And then, of course, we were aware of all the groundbreaking work others had done with psychedelics in the past, really reputable research by Stan Grof and many others. And then the case reports about MDMA being useful in therapy by George Greer and many others. So what struck me after a while practicing psychiatry was, wait a minute, drug companies are researching random compounds that they discover. Here are compounds where there's quite a lot of anecdotal evidence, at least in the case of MDMA, by reputable people saying that this is really could be helpful in therapy. So why is it not being researched? It was really that. It felt ethically actually unacceptable for physicians to be ignoring these leads instead of vigorously researching them. So that's having no idea what I was getting into.
So Annie, you're a psychologist, is that right?
No, I'm a nurse.
Okay.
I'm a nurse, and I started working with Michael when he switched to be a psychiatrist and had a private practice. So we worked together with a number of patients, and we did breathwork groups after we did our own training in breathwork and became certified. Michael and I led breathwork groups for 10 years with some of the people that came to the private practice, and just some people, just would come for the groups. But we saw what an incredible healing process that was to do breathwork along with psychiatry, along with therapy. But it also didn't cover everybody, There still were people that we knew maybe needed something different. We did EMDR in the office and neurofeedback, so many things, but wanted to try. So we knew, like Michael said, we knew that MDMA was really useful for communication and some of the other anecdotal things that had been written about it. So thinking that maybe that would be a way to help some people with PTSD. Michael's practice really had quite a number of people with PTSD.
Was that deliberate, or as a result of your time in the emergency room, or was that you got a reputation for being effective, or what?
Yeah, I think it wasn't so deliberate, but it was a natural interest I had. And during psychiatry residency, I was clinical chief on the trauma unit in my 4th year, and I was very interested in that. And then it just kind of happened. The more people came with trauma, the kind of I got known as somebody that treated trauma a lot.
Well, I think also, Michael, that the fact that you did EMDR early on, before a lot of people were doing EMDR, you got a lot of referrals from other therapists that said, maybe let's try some EMDR with Michael, or try some breathwork.
I'm not sure all my listeners will understand what EMDR is. One of you like to kind of clarify that, explain that to them, what you were doing? Maybe Michael?
Sure. EMDR stands for eye movement desensitization and reprocessing. It's a technique that Francine Shapiro, a psychologist who recently died, unfortunately, Francine Shapiro kind of happened upon this phenomenon and then really ran with it and found that it appears that alternating bilateral stimulation can help people with emotional processing. So it usually involves watching a light go back and forth, so your eyes are moving back and forth as a way of stimulating emotional process. So that was another thing that many people thought were crazy at first, but then turned out to have good data. So it's another way of processing trauma that I think can be very useful.
So you were looking all the time as a team, you were looking for ways of improving the outcome of people with PTSD, and because traditional psychotherapy isn't so good at that, is it? And you're trying these different biological treatments. And then what, you read the paper by Greer, or were you friends with him? I mean, how did you get into the MDMA circle?
Well, initially I just read George Enrique's papers, but then when we got permission for the first study, we wrote to George Enrique and asked if we could come out and take them out to dinner and learn from them about how they did it. So we met them early on, and they were very gracious to have us at their house. And so we've been friends since then.
So you decided just to set up an MDMA study in your own practice. I mean, that's a serious challenge. Were you in a university, or was it just private practice?
No, I was not in university. I was on clinical faculty at the university, but I didn't work there and didn't do much there. Yeah, as I say, probably luckily I didn't know what I was getting into. So I just decided this is not acceptable. We got to research this. So I approached Rick Doblin. I'd never met Rick, but we were MAPS members. We were interested in their mission. So I just approached Rick and asked him, I actually said, which offshore country do you recommend I go to do MDMA research? And Rick said, oh, you can do it here and we'll help you. That was in January of 2000. And
originally we thought you were going to have to do it at the Medical University of South Carolina. That's where we thought we would do it. And then we couldn't get approval.
Oh, you mean the university stopped you?
Yeah, well, we couldn't get the IRB to look at it.
Right. Okay.
And so then we went back to the FDA and said, no, could we do it at the office, our private practice? And we got approval for that.
Yeah, what Rick said, why don't you go home and write a draft protocol, and then we'll take it from there in early 2000. So not knowing any better, I went home and did that and got a lot of help. We actually took another couple out to dinner. So we knew Kathleen Brady and her husband, Bruce Lydiard, both psychiatrists and researchers, and Kathleen was the PI on the Zoloft trials. So when we got back after Rick said, why don't you go write a protocol, I called up Kathleen and said, could we take you and Bruce to dinner and ask you how to do clinical research? So we had a conversation with them at dinner and got a few tips, and then got a lot of other input from real researchers along the way, of course, but that's how it started.
How did you deal with the problem of having to keep the drug safe? This really dangerous drug you have to keep locked up. I mean, did you have to get special assessment by the FDA and the DEA to be able to do this? Did you?
We certainly did.
Oh, yes.
We certainly did. Happily, it took us about a year to get the protocol finalized. But then when we submitted to FDA in October 1st of 2001, we got FDA approval on November 1st of 2001 after a conference call with them to sort out some details. So it was strikingly quick right at that first step, but then it took until that was fall of 2001. It took until March of 2004 to get the other approvals we needed, the DEA and IRB, which was a whole nother twisted story. We went through a few IRBs. So there was a lot of delay with DEA. Inspections, a safe. They actually had to investigate the therapist in the office across the wall from where we had the safe because they were afraid she would drill into the back of the safe. I called her up and say, hey, the DA wants to check on you. Can I give him your contact information? She said, yeah, but just tell him I'm not good with tools. So there was a lot of that, which always, caused a lot of delay, but we did get through it.
It's similar. It took us 2 years to get permission to do the first psilocybin. And, the fact that I have to have a special safe with a camera to hold psilocybin, where you can pick the mushrooms outside. It always seems to me kind of absurd. But these organizations, they create a mystique and a fantasy, which kind of justifies their existence, I think.
Yeah. Well, when the DEA people were there inspecting the first time, this big safe with the alarm on the safe and an alarm on the building, I said to the DEA agent, and I said, we don't want anything to go wrong any more than you do. I'm just surprised that you're that worried about the small quantity of MDMA when people could probably go down to the college campus and get it a lot more easily. And what the agent said was, yeah, but people who take this stuff are so crazy, you don't know what they might do. So yes, that was kind of the attitude we were dealing with.
Drug crazed criminals, yeah.
But once they found out we were following the rules, they've become reasonable to work with. We haven't had delays from the DEA in recent years. That was only in the beginning.
No, absolutely right. Yeah, you do what they say, you do it right, and then they get confidence in you. Yes, you certainly can't. They have ultimate power. There's no point in fighting them. You've got to go with them.
Yeah.
But you did it, and then you got a trial, and it was tell us about the trial, because it's just a landmark study in the history of psychiatry.
Yeah, I want to emphasize how much support and help we had in doing this too. It was a real team effort of a lot of the hardworking people at MAPS, so it definitely wasn't just us.
Mm-hmm. And some of our breathwork friends helped us get the music together, and so talking about how the room should be, and so we had a lot of help from people.
But the design, let's just look at the design, because as I say, it's become actually the de facto kind of design for all MDMA trials, certainly since that's what we've kind of used it as well. So you decided, I think, was it 16-week psychotherapy, weekly psychotherapy, and then two sessions of MDMA interspersed in the middle. So why did you choose two? And
we chose two because we thought we didn't know if we could get approval from FDA for any sessions. So a lot of the decisions, it's interesting now to look back at the protocols and the way they've kind of become reified.
Yes.
And a lot of it was just decisions I kind of came up with as best I could based on, along with Rick and others, we all brainstormed a lot about it, but we modified it we tried to strike a balance between what we thought would be ideal and what we thought the FDA would allow. And of course, we didn't know where that point was. But that was the reason for two. We didn't think two was necessarily the ideal number, but we thought it was a reasonable number, and we thought any more than that, the FDA probably wouldn't.
Okay, I see. Right. So you were pitching for the most you thought you could get, and you got two.
Right. And then when we had data halfway through that first study, when we sent them the safety data, we asked for a third session, and they granted it then. So basically, it's been a process of starting very conservatively, and then as we get more data and we get more comfortable with it and the FDA gets more comfortable with it, we've modified things. We've increased from 2 to 3 sessions. We decreased the frequency of blood pressure medicines and all that kind of thing. So it's really been a process of, again, balancing what we thought clinically made sense, what we thought made sense from a research perspective, and what we thought we could get approval for.
So yes, you intimated the very first study you had to do quite a lot of safety monitoring, didn't you? Just to make sure that the myths it was going to cause hypertension and heart attacks were myths.
We did, yeah. We had to have blood pressure checks every 15 minutes for 4 hours and then every 30 minutes for 2 more hours.
Sometimes every 5 minutes if it went above the thresholds.
Yeah. So we've, got the FDA has agreed little by little. Now we only do the blood pressure 3 times the whole 8 hours.
So let's talk about the overarching design and then come to the MDMA sessions in a minute. So you have I think is it 16 weeks? Is that right? 16 weeks overall?
Yeah, roughly. Yeah.
So how do you structure those 16 weeks?
So first, of course, careful informed consent and careful screening, medical and psychological screening by outside physician and psychologist. And then we think the preparation period is very important. Once we've established that they meet the criteria and we taper them off any psychiatric medicines, then we have 3 90-minute preparatory sessions, because we think it's really important not only to establish a relationship with people, but to orient them toward this approach to therapy, which is quite different from what many people had experienced in that it's rather non-directive. We call it inner-directed. So instead of telling people this is what you should do, we invite people to be curious and have as little agenda as they can about what the session should be, and then to discover what their own inner process, the way that unfolds. So we want to orient people toward that possibility. Also let them know sometimes, unlike many psychiatric medicines that are aimed at directly decreasing symptoms, this is aimed at processing the underlying psychological experiences that are leading to the symptoms. So in that process, they might feel more symptoms before they feel better. And it's important for people to know that ahead of time so they can decide whether they want to do it, and also be prepared for the fact that if that happens, it's okay. As long as they're supported and working through it, it can be part of the healing process. So that's why we think the preparation is so important. And then, the MDMA sessions, there are only 3 of them, about a month apart. They're 8 hours each. But then there's a lot of attention to integration sessions afterwards, follow-up to help them work with whatever might get stirred up, and also to integrate what they're learning and what they're experiencing into their lives.
So, and the MDMA sessions were 125 milligrams, and then a top-up was 62.5 a bit later on. Is that right, after a couple of hours?
In most of the studies, yeah, we did test different doses from 25 up to 150, and we basically arrived at the therapeutic range seems to be around 75 to 125 seems to be a good range.
So then when you go into the first MDMA session, so people, they take the pill, eye shades and earphones, or talk us through how that session rolls out.
So what we do ask them to do is to talk about any fears and concerns before they take the pill. And we have some agreements about staying through the session. And for some of the studies, they spend the night at the office with a night attendant, and then we see them the following day. So some agreements about touch, and then they take the pill. And then we suggest that they go inside by putting eye shades and headphones on and listening to some very quiet relaxation type of music for the first hour. And then we would check in at about an hour if they hadn't come out and talked to us. So we say that, anytime they have something they want to talk about, feel free to come out. But the best way to do that first hour is just quietly and see how the MDMA comes up. And then as the day progresses, people start to have a rhythm of coming out and taking their headphones and eye shades off and talking to us about something. And then if it gets a little long-winded and they seem like they've talked a lot about something, pretty hard or something that has a lot of depth to it, we might suggest going back inside with their headphones and eye shades and just see what is there and see how the medicine, MDMA, is helping them and their inner healer. And so the day kind of goes back and forth like that with music if people are comfortable with it. The music changes and starts to have more of a emotional content. We use music that doesn't have English words. And then gradually it goes back to a more relaxing type of music towards the end of the day.
So they're prepared for an experience, and they're prepared, you encourage them to use that experience to think about important things. And I guess that mostly they think about the trauma, yes?
So we tell people that, if they haven't brought up the trauma during the day, or, sometimes people do not talk about the trauma that day, but they'll talk about it the next day. But we say we would like the agreement to gently bring it up if it seems like an appropriate time. But yeah, we tell people that whatever comes first is, how their process is developing. And sometimes people have very positive experiences before they go into the trauma. Like, I survived, or I'm in a loving family now, or things are different, and experiencing that before they dive into the trauma. And some people, right when the medicine comes on, they are right in the trauma, just like revisiting. We've had a number of people where the session is like that, and then they're just there re-experiencing it in a different way with the MDMA.
Would that be the heart beating and that, and getting them the sort of somatic symptoms, perhaps provoking the memory, would it?
Maybe.
Yeah, that's interesting, because sometimes people do have trouble with, they feel the autonomic effects, their heart beating faster, and they kind of, it can feel like a panic attack, and it can feel as if they're losing control. So sometimes that does bring up the trauma for people, but in general, we find that during that period, if they're having that experience as the medicine's coming on, we just encourage them to try to relax and realize that it'll pass. And that's quite different from the approach we take to anxiety later. Later, we encourage people not to try to relax if they're feeling anxious. We try to encourage them to try to experience and express what's coming up and explore it. But it seems, for practical reason, people can get kind of sidetracked by the initial effect of the medicine. It just seems usually, not always, but usually more helpful just to kind of get them through that. Then they start to feel, okay, I'm going to be okay. And then they can grapple with more difficult stuff later. It's usually the way it works. But we find that there seems to be value in this relatively non-directive approach for the reasons Annie says. Some people seem to do really well with processing some other kinds of things first, and then the trauma. Other people go straight to the trauma, and it seems to work well just to honor their own individuality.
Yeah, so one thing we didn't make clear, is the two of you always there with the patient, is that right?
Yes, we're always there. We do say that we'll maybe take a break and go get our lunch in the other room, but very often we will maybe bring that lunch back to the session and eat in the room so that we don't miss anything. But yeah.
No, they're never alone. One of us is always there, and both of us are almost always there.
Well, pardon me for butting in mid-episode, but I wanted to say a huge thank you to all the drug science community supporters. It's thanks to your donations that this podcast is possible. To thank our most generous community members, on the 8th of June this year, 2021, we will host a live podcast recording event exclusively for our premium and philanthropic community members. In this special episode, you can be the host and you can ask me anything. If you want to come to this recording, there's still time, assuming that is you're not listening to this in the distant dystopian future. There will be a link to the event in the show notes for the current premium and philanthropic community members, and information how to become a member to join me on the 8th of June. I look forward to seeing you then. And now, back to the show. And in terms of the sort of mental processing, I guess there will be people who are sort of single primary horrible trauma, but then there will also be some who've had that, but also have got a history of trauma in childhood. And is there a different process for them? The ones who've got chronic trauma compared with one acute trauma?
Well, the nature of the experience is going to be different, but the approach that we take is not different. In a way, this relatively non-directive approach is sort of self-correcting in that way. But if we encourage people to be open to their own experience rather than having an agenda, it kind of ends up accommodating those differences quite well, usually. That, what they process will be different if they've had childhood trauma versus a single incident, but the way we approach it is essentially the same.
And people with childhood trauma or with lots of traumatic experiences don't always have to talk about each single one. A lot of it happens with the MDMA inside, where a lot of it is just kind of taken care of with their inner process. And then they may talk about a few things, that they really want to have a witness to and tell that part of it. But so much happens too that we don't hear about as far as the inner process.
And most people we've in the studies have had more complex trauma or multiple traumas. Some have had single incident, but that's been really less frequent than people with multiple traumas. And interestingly, in our recent study, we found that in a couple studies, in one pilot study, we found that people with more adverse childhood experiences did just as well as people without adverse childhood experiences. And then in the more recent phase 3 trial, we found that people with dissociative subtype, which happens of PTSD, which happens, more often with people with early trauma, those people did at least as well as the people without dissociative subtype. So that's an interesting,
Cool. That's not just interesting. That's very exciting, because they tend to do badly under traditional psychotherapy or traditional medication, don't they? So that's very.
They had actually in the phase 3 trial, they had a larger drop in CAPS in the dissociative subtype group with the MDMA therapy, but not larger with the therapy alone with placebo. So, we got to pursue this more and see if it holds up. But I think that's exciting development.
So, Michael, you've made mention of the new study, which is not just a new study, it's also a breakthrough study. So why don't you tell the listeners about that?
Yeah, well, this is our first phase 3 trial that was just published. And the way it works is, the studies we were talking about before were the phase 2 trials. MAPS sponsored 6 of those. We did a couple of them, and others did them in US, Canada, Switzerland, and Israel. And so that data is what got us permission to move into this larger phase 3 trial, which is the last phase before you can apply for a new drug application. You've got to do 2 phase 3 trials normally. So we have been working on that for several years, and we just finally published the results. And the agreement we had a special protocol agreement with FDA that was an extra level of review for the protocol. And they, that agreement said that if we reach a statistical significance of 0.05 with this protocol, comparing MDMA plus the therapy with placebo, then that's adequate for approval, although we need 2 of those. So what we found was, even though we had to decrease from 100 to 90 because of COVID, FDA agreed that we could stop there. So it was a bit of a risk that our statistical significance might be less. But in fact, it basically took our breath away when we learned that the p-value was 0.0001.
That's to die for. You won't beat that again in your lifetime, I'm sure.
I don't think so. That'll be okay. If the second phase 3 comes at 0.05, that's all I care about.
Yeah.
Well, what's the status of the planning for that then?
Well, the second phase 3 is now underway. I think about 30 people have been enrolled out of the 100 now. Just
thrilling.
Just getting going. They haven't all been treated yet, but we're getting going. And then we, of course, as you know, we have trials coming up in England and Europe, phase 2, and then phase 3 trials that are revving up now. And we're hoping that within about the next year, we can complete the second phase 3 trial and then apply for a new drug application for MDMA to have an indication. Not for MDMA to have an indication, actually for MDMA-assisted psychotherapy to have an indication for PTSD.
And actually, Annie, you were saying, I think before, that you've managed to run a study as big as this in many centres around the world. You've actually had to train up a lot of new therapists, and they've proved to be effective as well. Probably not as effective as the Mithoefers, but at least
they were. They were.
We didn't get to participate this time.
Did you not?
No. So yeah, that was also across all of the sites. Every team of therapists did as well, and there was no difference from one site to the next. So that was really good to know that our training had worked. And yeah,
that was 13 sites in 3 countries, US, Canada, and Israel. And our role in this study was to support and supervise the sites. We didn't get to treat anybody ourselves, so we can't take credit for the therapy in this one.
Right.
Take credit for the training, I would.
Yeah.
Obviously, there are other very big players in this field. I mean, people like Mithoefer have spent their life looking at ways of dealing with trauma and the process of sort of systematic extinction, desensitization, etc. How were they receiving this new data?
Well, it's been an interesting progression. The more data we've published in reputable journals, including yours, the more people have thought maybe we're not as crazy as they originally thought we were. So actually, we're now, one thing we're doing is we have a department now that I'm the medical reviewer for investigator-initiated trials. So other investigators now many of them are coming forward and wanting to do studies and use the MAPS MDMA. So actually, one of those trials that's under development now involves Edna Foa and some people she's trained in Israel who want to experiment with MDMA with prolonged exposure therapy. So that's kind of where that stands. Barbara Rothbaum, who's also a very prominent prolonged exposure therapist and researcher at Emory, she's also probably before the FOA study maybe is going to be doing a similar thing with MDMA with prolonged exposure. And then, we did a study with Candace Monson, who developed cognitive behavioral conjoint therapy with couples. And we did a study with Candace and Ann Wagner from Toronto, combining MDMA with cognitive behavioral conjoint therapy for couples. And that we had promising pilot data there. So I think it's been a real shift that people who are interested in other methods are now looking at how can we combine MDMA maybe with other approaches too.
So, I'm asked all the time, how does it work? And in fact, I have just written a commentary on your study, which will be out by the time people hear this podcast, because your study came out today and mine they're still going to publish in the next couple of days. And the way I've tried to understand MDMA is in terms of its interaction with both the emotional, particularly in interaction with the emotional centers like the amygdala and the ability for it to kind of restrain excessive amygdala activation so that people can cope with the emotion and deal with it. Does that make sense to you, or do you think I'm being too simplistic?
I think that makes sense. Basically, David, you're in a much better position to explain how it works than we are, because you're a neuroscientist. And we've mainly studied whether it works and whether it's safe. But of course, we're really interested in how it might be working. I think that's part of it. I also really like what you and Robin Carhart Harris have written about the relaxed beliefs under psychedelics, that idea that by the changes in the networks relationships, people have a possibility for a new perspective and a new experience. That makes a lot of sense based on what we're seeing, along with the idea that, the amygdala is turned down and you can process more effectively without being overwhelmed. I think that and a lot of other strands of research are very exciting. My take on it is it's exciting how much we're learning and how much we have to learn. I am concerned about effort, that we avoid falling into reductionist thinking, because we are just struck again and again by how complex and deep and wide and rich these experiences can be, and what people describe about these very complex processes that have many different elements. So I think as we learn these other aspects of why it may be working, I don't want to miss the chance to learn something even bigger or new about the nature of psychological healing and how the psychological part interacts with the biochemical part. And it's obviously all happening. And I just think it's much more complex than any one of these theories alone.
Sure, you're right. I think that the challenge, of course, is it's easy to measure the amygdala, but it's quite hard to measure more complex constructs, like making sense, trying to make sense of why you were in the war in the first place, and should you have signed up, all those other factors, which people reflect on when they've been traumatized, the sort of the self-blame, etc. So yeah, but it's good. I agree with you. I think the explanations are going to be multiple and possibly different in each individual.
Yeah. Yes, that too.
That too. Yeah.
Just to make it complicated.
Now, one of the great, there's a lovely video you show. I think one of the great messages we've got to get across, because still, when I talk to colleagues, even if I talk to psychiatrists who should know better, but certainly if I talk to other doctors and they say, oh, come on, you're just giving people a trip and they're having fun, no wonder they feel better. And I always give them this wonderful quote from that patient of yours. It's when he comes out and he says, I can't believe why they call this ecstasy.
Right.
Because it's not. It's just really challenging, difficult, and painful. And that's probably why it works, because people are actually going where they haven't been able to go before.
Yeah.
Yeah. Processing trauma is challenging with or without MDMA. It just may be possible with MDMA where it hadn't been without it for some people.
I want to talk to you about you two, really, because, obviously you're very effective. And I imagine you're effective because you both signed up to this and you both worked together as a team. But I remember I've written several books on PTSD, and the first one, there was a Dutch psychiatrist who used to specialize in treating people who treated PTSD or the first responders. And his view was that, it's a fact that it's tough. I have to say, of all the patients I've treated, the ones that I found most disturbing are the PTSD patients, particularly the ones who've been tortured. And actually, to be honest, I kind of, I find it quite difficult. How do you guys as a pair cope doing this all the time?
To say I enjoyed it would be kind of be a ridiculous statement, but there is something about working with people in a deep state that I am just drawn to. I love the deep processing, and we've worked with people just in our private practice that dissociate or have lots of trauma from childhood. And I really love to see the healing process happen and see them get better.
I think you've answered what you've said, Annie, is that you do it right and they get better. And I was doing it not very well. And I wasn't getting it better. I can absolutely see the pleasure in getting it better, because I never really saw that.
Well, yeah, maybe that's the case. But I've also seen people not get better and struggle for years and know that there could be other things that might help them. But when, this isn't for everyone too. MDMA therapy isn't for everyone. We can't make everyone do it. But how about you, Michael?
Yeah, I think that's part of it. The fact that when you see results, the more we have the experience of people going through really challenging times, and then that pays off, which we saw with breathwork too. Sometimes I saw that with other kinds of therapy. I was interested in kind of depth therapy, but it was a lot slower and less frequent that people had these really profound changes in a relatively short period of time. So that helps. And then, it helped. Sometimes it was very difficult emotionally for us, especially treating young women about the age of our daughters. When we did the first study, our daughters were in their mid and late 20s, and we had some participants around their ages, and we'd sometimes sob on the way home. And have the chance to process it together was very helpful. So we needed our own ways of working with the effects of hearing all that stuff, for sure.
Self-care, yeah.
No, that's vital. And obviously, you're the perfect pair, because you can really know what the other person's gone through, don't you? You've been there with them. So what's the future? How are you hoping it's going to roll out, Michael?
Well, I'm excited that as we get older, all these brilliant, enthusiastic young people are coming along and taking the effort forward. So I'm really hoping that the second phase 3 trial can be finished within the next year or so and get good results. And then MDMA-assisted therapy could be approved by FDA within a couple of years, and maybe by EMA and British authorities a year or so after that. So I think I'm hopeful that while it's important to recognize that this isn't like the best thing since sliced bread that solves all the problems, for sure, I think it can be a very powerful tool and could have a good effect on psychiatry, because I think a lot of psychiatrists are very frustrated with the limitations of the treatments we have. We've had psychiatrists in our trainings watching the videos sometimes burst into tears and say, this is why I went into psychiatry, to see this kind of change, and I haven't been able to do it.
Yeah.
And do you think what we're seeing in the psychedelic field is we're seeing that the sort of target indications are broadening? Do you think we'll see that with MDMA, or do you think it really is just good for trauma?
I think we're going to see it with MDMA. We already have significant improvements in depression scores in our PTSD study, so that should be pursued. As you well know, there was a good British study of MDMA-assisted therapy.
I wasn't trying to get this.
Alcoholism. So I think that's an important avenue. And there's an eating disorder study about to start. MAPS has sponsored pilot studies on MDMA-assisted therapy for anxiety in people with life-threatening illness, similar to the psilocybin studies for that indication. We've done one. Charlie Grof and Alicia Danforth did a pilot study with MDMA with social anxiety for people on the autism spectrum. We're getting IITs to study many other things, fibromyalgia. A lot of other ideas are coming forward. So I think my guess is there's going to be expanding research into a number of indications.
And working with the couples, the relationship, that was just beautiful to see how that worked for the two people together.
Yeah, just remind the listeners how, because that's how it started, isn't it? It started with the Shulgins, and I've forgotten her name, but her encouraging therapists, Anne Shulgin. Tell us a little bit about that then, please.
Oh, yeah. The couple study was just a beautiful study to do together with Candace and Anne. So they are CBCT, cognitive behavioral conjoint therapists, and have a manual that Candace wrote. And we combined that with our MDMA manual. So we had 6 couples, and one person in the couple had to have PTSD. The other person didn't. And they each got to take MDMA on 2 occasions. We started together. Yeah. And we started those sessions being 2 weeks apart, and then we went to 3 weeks apart for a little bit later in the study. All of the cognitive behavioral conjoint therapy really was either a prep session or in the integration sessions. And then the MDMA sessions were pretty much just how we do it. And, it was so beautiful to see people talking about the traumatic events that they had never shared with their partner and how well they did together, listening and comforting each other. And it was really beautiful. And to see how the cognitive behavioral conjoint therapy worked as an integration tool, because they did all of the homework together and working on, the thoughts and worksheets.
Well, it would be wonderful if we could roll MDMA out for couples problems as well, wouldn't it? It could save a lot of marriages, I suppose. Wow. That's not a diagnosis, though, is it? That's the problem.
The diagnosis system is a big problem, as you know.
Right.
And along those lines of saving money, we're also working on getting a group therapy study going in Portland, so that to see how we could change the ratio of therapists to participants and another way to make it more cost effective. So that's going to be pursued.
For PTSD?
For PTSD, yes.
Mm-hmm.
Yeah, interesting, isn't it, that? Because I was always very skeptical about the use of psilocybin, which is where I have more experience in trauma and anxiety disorders. But in a lot of military people seem to be going to ayahuasca in groups, ayahuasca retreats.
Yeah.
And it may be that the group sessions are actually in some way better for people who've been traumatized in a group, like in a platoon or something.
It may be. We're going to try to find that out, and especially if their trauma is similar enough. You get
yes, absolutely.
Group, like all veterans with war trauma in one group. Yeah, I think it's very promising.
I think that makes a lot of sense. Well, we're going to have to bring it to an end now, and it's been fantastic talking to you.
Oh, so good to spend the time with you too.
I really enjoyed it, David.
Well, I want to thank you on behalf of the listeners, but I want to thank you on behalf of patients as well, because you're true pioneers, and it's been a pleasure seeing what you've done, having a chance to referee some of your papers, get them published in my journal, and now the ultimate accolade to interview you together. So thank you both very much indeed.
Thank you.
Thank you, David.
So good to be with you.
Well, that's the end of this episode of the Drug Science Podcast. Thank you for listening. But before you go, I would just like to share with you a question from our drug science community members. Recently, we recorded a very special podcast episode in which we invited all of our premium and philanthropic community members to ask me anything they like. Their questions were so good, I thought we should include one or two of them at the end of every podcast episode. So please enjoy this new segment of the show. Apologies for the audio quality as we recorded the session over Zoom. Hopefully they're vaguely relevant to what we've been discussing. And if you want to ask me anything, perhaps we could do an Ask David Anything Part 2. Enjoy.
Yeah, hi everyone. I'm actually a new member, so I'm very happy to be here. David, I actually just want to mention and express my gratitude for everything you do. And actually, one of the reasons why I've decided to study neuroscience is because of your research. So my question is about psychosis. Do you think psychedelics can be used to model and develop treatments for psychosis and schizophrenia? And are there any ongoing or planned projects that can provide us with a better understanding of the neurological basis of the disorder? Thank you.
So, I mean, of course, historically, one of the sort of four rationales for using particularly LSD in the 50s was to model psychosis. And also to give doctors, particularly psychiatrists, an insight into what it was like to have an altered state of consciousness that could potentially give them more empathy for their patients, who were also, some of them would have been psychotic. And actually, that's in some ways one of the problems with the early work with LSD, because that was relatively convincing, and therefore people assumed that because you could model psychosis with LSD, then it was dangerous. They ignored the fact that almost always, the experience is to do with the drug being in the brain rather than having any long-term consequences. But there were some examples of individuals whose psychosis was aggravated or precipitated by LSD, and some of them were, musicians. And it's been, there's been this argument that it's dangerous because creative people can actually potentially become uncreative and damaged by it. But historically, if you look at the historical data back in the 1960s and 70s, I mean, there's 40,000 people were given, psychiatric patients were given LSD, very few had psychosis. But what we have done recently is, we did two things. About 10 years ago, we did a survey of symptomatology under various drugs. And we looked at cannabis, the data on THC. People have used THC, John Crystal's group in Yale, to model psychosis. Similarly, that same group and others have used ketamine to model psychosis. We looked at some of our volunteers and other people's data on psilocybin. And psychedelics, although they don't perfectly model psychosis, they're somewhat better than both ketamine and THC. And they get to sort of about 3/4 of the way to being schizophrenic or psychotogenic. And of course, all of them really miss out on the fact that they don't cause auditory hallucinations. But because of that, I was working with Professor Mittal at the Institute of Psychiatry. And a few years ago, we got a grant to essentially give normal, healthy people psilocybin and try out a possible new treatment for psychosis. And this is a very interesting concept. This drug was called saracatinib, and it's actually developed as a treatment for prostate cancer. It works in a completely different way. As you probably know, all antipsychotics pretty much work to block the dopamine receptors. But this drug is a tyrosine kinase inhibitor, so it blocks a particular enzyme in the cell, which is why it was developed as anti-cancer treatment. And why was there any interest in it being something to do with psychosis? Because it got removed as a treatment because it had too many brain side effects. So it was getting in the brain. And the company that had it was AstraZeneca. One or two of their scientists said, I wonder what it does in the brain. And they, quite interestingly, just off their own back, they did a study where they gave it to rats and then gave the rats LSD and discovered it blocked the effects of LSD in the rat. And then they actually approached us and they said, do you think it might block the effects of psilocybin or LSD in humans? And we showed it did. And we showed it did have a moderating effect. It didn't eliminate them, but it did have a moderating effect. So, I mean, the drugs that eliminate them completely are 5-HT2 blockers that sit on the receptor and stop the psilocybin LSD getting to the receptor. But it attenuated some of the symptoms. And in fact, it was sufficiently strong that Mittal has gone on to, he's doing a study. He's actually using saracatinib as a treatment for sort of prodromal or early onset schizophrenia to see if it might work in this more mild case where, you don't want to give a dopamine blocker because you might sensitize the system. So yes, so the answer is it's an interesting approach. We are using it. results are tantalizing at present. And of course, they could be used to study in humans all sorts of other treatments. So it's much faster, of course, to do it in a volunteer with a psilocybin on board than it is to find people with untreated schizophrenia or psychosis. All right.
Just to add a little bit, so thank you so much. It is very interesting. And I believe there was a study that revealed that buspirone prevented some psychotic effects on psilocybin. Does this sound promising and relevant to you if we talk about psychosis?
But buspirone was developed, interestingly, as an antipsychotic. It just didn't work. It's conceivable. I mean, it has a very low affinity at the 2A receptor, but it does have a very high affinity at the 1A receptor. And this is maybe a bit too technical for those of you who aren't pharmacologists, but there are two main serotonin receptors in the brain. The 1A receptor, which turns off the brain, and the 2A receptor, which turns on the brain. But they're often sort of linked. So if you turn on the 1A receptor, it actually turns off the 2A receptor. So that will be my explanation as to why buspirone might have some moderating effect on its sort of reciprocal interaction between these two receptor systems.